Friggin' old people. It's estimated that 35% of all operations performed are on people 65 years of age or older, making the geriatric population one of the most common you'll see in an operating room. And that number is expected to increase as the baby boomer generation continues to age. What makes this one of the biggest issues, though, is the geriatric population is one of the most diverse in health and medicine. They can range anywhere from being healthier than your average 20-year-old to being an absolute train wreck. From lifelong habits to the natural aging process, there are a whole host of conditions that can complicate even the most routine of surgical procedures. My name is Richard Hanscom, and in this video I'll be discussing the geriatric patient in the OR, some of the complications that you can expect, and some of the ways you can prevent or solve these before they even become an issue. I hope this helps. Geriatric patients experience a higher mortality rate than any other group when it comes to emergency procedures versus electives. Much of this has to do with proper planning not being possible. Roughly 80% of geriatric patients will present with one or more comorbidities, which is the simultaneous presence of two or more diseases or conditions within a patient. With so many potential things going on in the human body, especially with how comorbidities may interact, it's impossible to prepare for every situation for every patient every time. So it's that much more important that we get it as right as we can the first time. So let's briefly talk about transferring and positioning. As surgical technologists, we won't have much to do with the transferring, transporting, and positioning of patients. Most of the time we're going to be scrubbed in already. But even though we're not directly involved, there are things that we need to be aware of and pay attention to. If for some reason your elderly patient is transferring themselves to the table from a chair or bed, make sure they don't fall. From declining strength and balances and reflexes and coordination, to low O2 saturations and problems breathing, to arthritis, to bad proprioception, which is the sense of knowing where all your limbs are without even having to look at them, to orthostatic hypotension, which is that dizzy feeling you get when you stand up too fast, to even just general confusion or declining mental status. Old people love to fall down like it's their job. And because of weakened bones from osteoporosis, thin papery skin that's lost all of its elasticity, and a lack of adipose tissue or fat cells, elderly patients are more prone to injury from falls than any other group. And thanks to a declining circulatory system, blood circulates more slowly through an older person, so their healing and recovery times are only getting worse with age. Yay! Now, if they're being physically transported by other people, probably like they should be, there are still other things to watch out for. One is called shear forces. Shear forces are kind of like a rug burn, except instead of the rug and your knee, it's a person's skin and, in this case, a sheet. An older person's skin can be so fragile that if you rub them against a sheet too roughly, you can actually cause abrasions or even breaks in the skin. Arthritis, limited range of motion, and weaker bones means that they're going to need an extra gentle touch when they're being held or moved. And since elderly patients are more likely to be catheterized due to low bladder retention, you're going to have to watch out for bags and tubes, and this goes for any kind of breathing apparatus and tubing as well. And of course, because of the lack of fatty tissue, older people have a hard time retaining warmth. And since the OR is kind of chilly, they're probably going to need a warm blanket as well. And remember, this is all before they're even on the table. Of course, limited range of motion and arthritis will come into play when it comes time to positioning your patient. The elderly are also going to experience a higher likelihood of hunchback or some other curvature of the spine, which is only going to make positioning more complicated. And then there are those pesky bony prominences. I'll give you time. Bony prominences are any hard or bony part of the body that comes into constant pressure with another surface. The pressure that, say, a bone and a bed make against the skin blocks all blood. If blood flow is blocked long enough, this can lead to pain and pressure sores. Common bony prominences include the back of the skull, your ears, the heels of your feet, your hips, and your tailbone, also known as your coccyx. Probably should have seen that one coming. Now, of course, all of these bony prominences and pressure sores are actually concerns for all your patients, but once again, the elderly patient is more prone to injury, what with their papery thin skin and their lack of adipose tissue or fat cells that would normally provide some cushion. And another complication to all of this is a depressed nervous system. A depressed nervous system means that they don't feel things quite as acutely as we do. You might say they have a higher tolerance to pain or a lower sensitivity to pain, but in either case, old people generally don't feel pain as acutely as we do. And because of the depressed nervous system, they may not feel pain at all, so they don't know that they're being harmed, or they may even underreport pain because they're just not feeling it as much as they normally would. Looking closer at the cardiovascular system, there's something really important we need to talk about, and those are blood clots. When blood leaves your heart through your arteries to the rest of your body, it's under a tremendous amount of pressure. That's because it's got your heart pumping behind it. But once your blood has dropped off all of its nutrients and oxygens and whatnot and is coming back through your veins, it doesn't have the power of the heart to pump it anymore, so it needs another mechanism, particularly the blood in your lower extremities or your legs, so it needs a different kind of pumping pressure. Enter the musculoskeletal pump. Can we get some, reverb or echo on that just so it sounds cool? No? I hate you. Now, it's important to remember that the musculoskeletal pump isn't actually a pump or a thing, it's an action. When we walk around, our muscles constrict and it ends up squeezing the blood up our veins, and it doesn't drop out because there's these little valves, but the more we walk, the more we encourage blood to return to the heart. This is called venous return. And this is an important action because when blood is allowed to just kind of hang out and chill and do its own thing and not move very much, it has a tendency to clot. And I shouldn't have to tell you that clots are bad, because if they get to your brain or your lungs or your heart, you're gonna have a bad time. You know when OSHA or your job says you should probably get up from your desk and walk around once in a while? This is why. Now, the elderly don't spend a whole lot of time getting exercise, unfortunately, due to arthritis and limited range of motion, declining muscle mass, and just general lack of energy. They just don't move around that much, and this is only doubly so in a hospital environment where they spend most of their time in chairs and beds. This allows blood flow to slow to a crawl, again, particularly in the lower extremities, and this, of course, leads into a higher formation of clots. Now, enter the point of this whole diatribe: sequential stockings! Ta-da! Sequential stockings are those big boots you'll see patients wearing. They're usually hooked up to some kind of pump. They're made to have a bunch of inflatable chambers that will inflate sequentially, mimicking the musculoskeletal pump and preventing clots. That's why they wear them. Now that you know what they are, what they're doing, and why they're doing it, if you see them on your patient, just take a second to look at them to make sure that they are hooked up, plugged in, and turned on. One last note about the circulatory system. Your patient may have high or low blood pressure. Both of these are sadly normal, but still warrant some attention. Now, hypotension, or low blood pressure, is often caused by hypovolemia, which is a lack of blood in the body. Low blood volumes are usually because of a lack of water or plasma in the blood, but hypertension can also happen. Since low blood volume can lead to lower blood pressure, the body tries to compensate for low blood volume by increasing heart rate and stroke volume, as well as constricting your veins to try to get your blood pressure back up. Of course, this overcompensation leads to hypertension. As for the respiratory system, there can be some complications there as well, and that's even without a lifetime of smoking or working in hazardous conditions. Both the lungs and the chest wall can experience reductions in both strength and elasticity, which will have a negative impact on tidal volume, or the amount of air that your lungs can hold, and tidal exchange, which is the amount of new air in and old air out. Low oxygen exchange means your blood's not getting as much oxygen as it normally would. So not only might there be some specialty breathing equipment, but there also might be a variation of position so that the patient can breathe more appropriately. Now, I know what you're thinking. This all sounds like a lot, and truthfully, it is. We've touched on a lot of subjects in this video, and technically surgery hasn't even started yet. So in an attempt to keep you engaged through an entire video that's quite frankly full of a lot of material, I've made some jokes. It's all based on either sarcasm or dark humor or what have you. And I could easily come off like I think the geriatric patient is a giant pain in the ass. A lot of people like to say, oh, who would you want taking care of your mother or your grandfather? But I think a more important question is, who do you want taking care of you? Do you want somebody who's going to see you as a spreadsheet of disasters that just need to be mitigated? Or are they going to see someone they can have a real positive effect with and make your quality of life a little bit better when nature is only making it harder and harder? As if it mattered how a man falls. When the fall is all that's left, it matters. And when I reach that age and I'm looking at that table and I know that no matter how routine it is, at my age and in my condition, getting up onto that table and counting backwards from 10, even though I know I'm not going to make it to 8, might actually be the last actions I take on this planet. And everything that is me, my memories, my experiences, everything will be gone. Now, I hope that's not the case, but it is a possibility. So I have to think, who do I want in my corner when that time of my life comes? Do I want someone who sees me as nothing more than a pain in the ass? Or that I'm someone worth saving? That I'm worth helping? I know who I want that person to be. And that's who I'm going to try to be. Who do you want on your side? Maybe that's the person you should be. Hope for the best, prepare for the worst. Thanks for watching. I hope this helped. And good luck.